When you move them, because you need to, or they'll get bed sores, they slap, hit, fight, grimace, they'll fist their hands because they're in pain. They're not in the same universe you're living in. So you have to bridge that gap. Complacency is probably the single biggest reason for failure to diagnose pain.
Hey out there, welcome back to the Nursing Home Abuse Podcast. My name is Rob. I'll be your host for this episode. Today we are talking about detecting pain in long-term care residents, particularly those with dementia, Alzheimer's that are cognitively impaired. Like how do we know, what are they doing to tell us that they're in pain, and what do we do about it? But we're not having that conversation alone. We had the fantastic Katherine Reab on to walk us through this process. But right now it's time for the Nursing Home Regulation Question of the Week and another opportunity for you to win the Nursing Home Abuse Podcast mug. It's the perfect vessel to drink your morning drink. How do you win it? You might ask. That's an excellent question. It's extremely difficult. First, you got to go to our TikTok, which is @JusticeForResidents. You're going to scroll. You're going to look for the Question of the Week video. For this particular video, or for this particular question, you're going to look for the thumbnail that has a picture of a wedge salad, a quarter of a piece of iceberg lettuce with blue cheese dressing on it. You're going to click on that. You're going to give us your answer along with your favorite type of salad. Is it fruit salad? Is it a Caesar salad? Is it pasta salad? My favorite salad of all time is a wedge salad. For my money, it doesn't get any better than half a piece of iceberg, cold. Gotta be cold, okay? Then you got to have your blue cheese dressing, but then you also have blue cheese crumble or Roquefort crumbles on top, like the real deal. Real bacon, as much bacon as you can stomach, and then some raw red onion. I have the palate of an 80-year-old man, which I think I've discussed that before, because that's been my favorite salad since I was maybe 8 years old. So anyway, comment your favorite salad and your answer to this week's question on the TikTok. Random winner will be decided on Sunday. Find out on TikTok or our website, which is schenkfirm.com/podcast/giveaway. The mug ships at the end of the month. Difficulty level this week, folks, I think is going to be medium. So if you get this right, go out and have yourself a delicious wedge salad with all the accoutrement, the onion, the bacon, the Roquefort, the blue cheese dressing. All right, here we go. Good luck. Under 42 CFR 483.908, how long may the nursing home's sprinkler system be shut down before an evacuation or fire watch must occur? Is it A, 10 hours, B, 24 hours, or C, 48 hours? And that answer is A. The nursing home either has to evacuate the residents or establish a fire watch if the sprinkler system is down for more than 10 hours. Again, we're talking about understanding the signs of pain in long-term care residents, but we're not having that conversation alone. We have the fantastic Katherine Reab. After a 20-year career as a computer engineer, Katherine Reab transitioned into nursing and discovered a passion for trauma care. Today, she serves as a forensic nurse analyst and legal nurse consultant with Integrity Nurse Consulting, where she helps attorneys analyze medical records and uncover critical case details. With broad experience from bedside nursing to leadership, she brings sharp investigative skills and clinical insight to support attorneys in medical negligence, personal injury, and criminal defense cases. And we're so glad to be talking with her today. Katherine, welcome to the show.
Well, thank you for having me.
So the first question is kind of the obvious question, and why is it for nursing homes, why is it difficult to recognize pain symptoms in those with dementia or cognitive impairment?
This is actually a broad question that covers many different topics, from complacency of the nursing staff, poor training, extremely poor staffing, and completely sorry, not understanding, the tech guy came in, not understanding the actual process of the non-communicative patient, whether they have dementia or they're unconscious, they have head trauma, various things like that. So understanding that is really critical. Most nurses don't, or they don't care to, which goes to the complacency.
So when you have somebody that's non-communicative, okay, at least verbally, what are the signs that you're looking for to know whether or not that person may or may not be in pain?
So there's a wide variety of signs we look for. Now, it's depending on the disease process that we're assessing. So for instance, dementia patients, they're extremely difficult to assess if you're complacent about their behavior. You go in and go, that's just Eddie, he gets all cranky, blah, blah, blah. Well, he doesn't have any injuries. He doesn't have any bed sores. He has no sign of injury. Why in the world would he be in pain? We know now that dementia, 50 to 80% of dementia patients have or will have significant pain, even without injury, because the areas of the brain that involve pain receptors are also affected by the dementia process. And what we end up is, when your brain works normal, it ends up exciting the pain receptors, which tell them they're in pain, whether there's an actual injury. And then you basically have inflammation of those nerve receptors, and they're in exquisite pain, even though there's not an injury. So, and that pain still needs to be treated. So you have to not be complacent. We have many tools that nurses are trained on, CNAs are trained on, in order to assess that kind of pain in the nonverbal patient. So if you see a patient who is, for instance, they don't want to roll off of one side, well, that happens all the time. So it can't be pain. You can't do that. You can't be that complacent. You have to go, okay, why do they want to be on that side all the time? Well, maybe 25 years ago, they had a hip replacement. It's starting to fail. They can't tell you their hip hurts. All you know is when you move them because you need to, or they'll get bed sores, they slap, hit, fight, grimace, they'll fist their hands because they're in pain. So you can't just say, oh, they're non-compliant, which is typically what we see happen. So someone with dementia can't be compliant because they're not in the same universe you're living in. So you have to bridge that gap. And complacency is probably the single biggest reason for failure to diagnose pain.
That's so interesting, because it's like, in my mind, I feel like I'm not a nurse, and I would never, I mean, nurses do the Lord's work, but I feel like we're only looking at least in the notes that I see, we're only looking at facial grimacing, but there's so much more. As you mentioned, there's behavior. There's like, oh, why are we getting mad at doing this or this? It's not just, where the person's eyes are squinched up.
Oh, yeah. Well, the problem with dementia, specifically Alzheimer's, the further you go into the disease process, the more mask-like their face becomes. And so those normal signs start going away. They're not a response anymore, or they're very minimal responses, which you really have to look for. So you can't look at just one thing to determine pain. For instance, the pain aid scale, it assesses multiple things because there's multiple reasons for the pain. And when you include neuroinflammation on top of that, well, most of the time they just go, yeah, Betty's just being cranky today. And maybe she is. But did you assess it? Well, here's where we get to the next problem. Nursing homes are for profit for the majority of them. Their patients are a commodity that they make money on. I mean, that's the hard business truth about it. That means they staff to the absolute minimum legally required amount of staff. So the reality is, when I look at records and nurses say, yeah, I did my assessment, it basically only says assessment done. It's like, really? So tell me what you did. And they don't document it. More than likely, their assessment was they popped their head in the door and went, okay. Because they don't have time. So it's almost wholly falling on the shoulders of the CNAs to do those moment-to-moment, day-to-day observations, because they're the one actually delivering the lion's share of care. And they're not trained to do it.
You mentioned a pain scale. Like, what is there a particular kind of pain assessment that's more common than others, or maybe perhaps better than others?
What PAINAID is, it's found to be 80 to 90% effective, and it's PAINAD. And it's a multi-step assessment that you go through. It includes facial grimacing, auditory noise, what kind of noise, but we go a step further and we assess breathing. So when you hurt, you breathe fast.
Right.
Okay. You can breathe and hold your breath when somebody. So I'm going, okay, my patient hurts. They can't tell me where. So you gently do like, well, they don't want to move this leg for me. Let me gently start to manipulate the leg while I listen and look at their face. And I hear and the breathing stops. I went, oh, I've got a pain set. Okay, something hurts here. Now let's dig deeper into that assessment. And unfortunately, for most patients in many nursing homes, they're just kind of muscled into position and it's like, oh, she's being cranky. Dementia patients are very mentally and emotionally difficult for nursing to deal with. It's hard to not become complacent. I've seen this 100 times. Well, on the 101st, the person is dying and you missed it.
Right.
So you can never get complacent like that. And unfortunately, we're humans and it happens.
So if you're walking up to a typical resident that has dementia it's not care plan for pain, okay? Mm-hmm. How often are we doing the pain aid assessment? Ever? Or is it
every shift? And the difference is, so, my experience predominantly is in trauma. We're doing things very, very, very fast. Mm-hmm. So we don't get to know our patients per se. Okay. In a nursing home, a long-term care environment, you do get to know that patient intimately. And you should be able to spot from the doorway a change of behavior. Well, this isn't normal for her. Slapping, that's not normal for her. Okay, let's look at what's going on. Instead of going, she's just being non-compliant again. Can we give her some Ativan? And I see that. So stop. She's not just like that. Let's find out why she's being like that. And even if that isn't pain controlled or pain caused, let's find out how we can redirect that behavior. Let's find out what we can do to support that patient through that behavior. It's very complex working for dementia or working with dementia patients. And it requires a really sound understanding of the neurology of it, the brain functions of it, because the brain will tell the patient they're in pain.
What is some advice if you had a family that had a loved one with dementia in a nursing home? What advice would you have them what advice would you give them in terms of pain management?
So there's an expectation that at least 80% of all dementia patients will suffer pain at one point in time or the other, either from old injuries, when you get old, our bones creak, you're less mobile, so you start becoming stiff and tight and painful because of that. So you want to look at the nursing home and going, what are you doing with restorative nursing, i.e., massages, warm packs, cold packs, things that don't require medication to do to make that patient more comfortable. And then going on, especially if you have a patient who is violent or, is acting out in those fashions. A lot of times we just medicate for the violence. You just medicate them down because they're dangerous. And they are. They're dangerous to the staff. They're dangerous to other patients because there's no filters left. But you have to now go in and say, why are they being violent? So if it was my family member, I've just been notified they were in an altercation or something, I would be, what is your pain assessment? Can I see it? Show me you did it. Don't tell me you did it. Show me you did it. It's a form. You fill it out. You either fill it out on the computer or you fill it out by hand, depending on how sophisticated your facility is. Now let's talk about what we can do. And you need to involve the physician in this conversation, or nurse practitioner who's doing this type of care. You need to get their social work people involved. You need to get the head of nursing involved. And you need to get the physician or medical provider involved, in all of you talking on the same page for how these assessments are going to be done. Now, it is within our purvey as a nurse to do it whenever we want. We don't have to be ordered to do it. Well, maybe that you need your physician to order them to do it. Q shift, every shift. You look at what medications they're already on. You have that reviewed and make sure it's not polypharmacy, which is contributing to their confusion in anger. This is a very complex subject. And I wish it was as easy as, here, everybody, please fill this form out once a shift. But it's not. And so and my mother-in-law just passed from Alzheimer's. Sorry. So as somebody who's been involved in that, getting the team, because we do medicine in a team approach. It's the head of nursing or the director of nursing or the charge nurse for that. You get in the physician or the physician's assistant or the nurse practitioner, their social worker, that's their patient advocate. That's the one who's advocating for the patient. And make sure they're advocating for your patient or for your mom or your dad or whoever. And get everybody on the same page and educate yourself. And that's a really tough thing for people who aren't in my industry. And it really is. There's some wonderful resources for families, caregivers of people who have, dementia or Alzheimer's. Remember, there are different kinds of dementia. Okay. Alzheimer's is just one. And go to those support and learn how to advocate for yourself. That's probably the most difficult part for caregivers.
Very well said, Katherine. Well, very, very much appreciate you coming on the show and sharing your knowledge with us today.
You are most welcome, sir. Anything I can answer, let me know.
Folks, I hope that you found this episode educational. If you have an idea for someone that you would like for me to talk to, please let me know. If you have an idea for a topic that you would like for me to talk about, let me know that as well. Be sure to enter the giveaway for the Nursing Home Abuse Podcast mug. You're going to want to go to the TikTok and tell us what your favorite salad is. Is it Caesar salad? I think Caesar for me would probably be a close second. I love a good Caesar salad with some anchovies on it. That's the best. New episodes of the Nursing Home Abuse Podcast come out every single Monday. And with that, folks, we'll see you next time. Thanks for tuning in to the Nursing Home Abuse Podcast. Nothing said on this podcast, either by the host or the guest, should be construed as legal or medical advice, nor is intended to create an attorney-client relationship between the host or their guest and the listener. New episodes for now are available every other Monday on Spotify, Apple Podcasts, or on your favorite podcast app, as well as on YouTube and our website, nursinghomeabusepodcast.com. Again, that's nursinghomeabusepodcast.com. See you next time.